Okay, so with therapeutic drugs of toxicological importance, there are several things that we're looking at. So we have to, of course, get the background very, very clear. So generally, drugs may have primary effects, that's the therapeutic, and also secondary effects. So the secondary effects could either be the side effects or the adverse effects. So all those side effects can sometimes be beneficial, or most often they are undesirable. For example, if you take some antihistamines or like cetirizine or diphenhydramine, you're giving to let's say a patient has a type of hypersensitivity reaction, and then you're giving this to a patient to take it in the night. If the patient also has this problem with insomnia, its side effects of its or adverse effects being sedation will help the patient. So apart from, let's say, dealing with pruritus, itching or whatsoever, it will also help the patient to sleep. Though that's not the primary purpose of the diphenhydramine or the cetirizine. Yes, so that's more of an adverse effect. Alright, so adverse effects can range in severity from the ones with very life-threatening conditions to. So these effects often make some patients unwilling to take drugs on a regular basis, and this lack of compliance represents a major practical limitations of pharmacotherapy. Right, so drugs, the adverse or toxic effects of drugs is based on several paradigms, like on target toxic effects, off target toxic effects, and then drug producing toxic metabolites, drug stimulating certain immune responses, and also idiosyncratic responses. So we'll look through them, we'll go through them one by one. Alright, so the mind map is more of a summary of everything, trying to brainstorm and bring back everything that we've learned about the therapeutic drugs of toxicological importance. So, with the onset toxic effects, it can occur as a result of overdosing or alterations in the pharmacokinetics of the drug due to disease. So, an example is due to liver or kidney disease or by changes in drug receptor interactions, and that can alter the pharmacological response. Example, changes in the receptor number. The adverse effects may be an exaggeration of the desired pharmacological effect. So, with the offset target toxic effects, um, it can occur when a drug interacts with an unintended target. So, few drugs are very, very selective. They're so selective that they interact with only one molecular target. An example of such a drug with off-target effect is um, tefenadine. So tefenadine, let's say, let me use the let me use was because it's no longer in the market. It's an antihistamine also, but it has this off-target toxic effect, which also inhibits cardiac potassium channels. Yeah, so the unintended inhibition of this potassium ion channel unfortunately leads to fatal cardiac arrhythmias. So terbinafine was withdrawn from the market because of this reason. And then one thing I can think of is the thalidomide disaster, or yeah, enantiomer. So enantiomers of a drug can also cause these off-target effects. So enantiomers are basically mirror image isomers of this particular drug. So these well-known racemic thalidomide administration caused so many issues. The R enantiomer of thalidomide was just an effective sedative, but the S enantiomer was a potent teratogen. Yeah, so this caused severe birth defects, such as ficomelia in an estimated 10,000 newborns in about 46 countries. Yeah, so it was a serious thing. So many other teratogenic effects too. With another common off-target effect is a drug binding to different receptor subtypes. For example, beta 1 adrenergic receptor is expressed on the heart and beta 2 on the smooth muscles of the bronchioles. So if you give a beta adrenergic antagonist, which is non-selective, the management, for example, the management of hypertension, you could actually induce bronchoconstriction, which is very, very detrimental in cases like asthma. Yeah, so non-selective beta adrenergic antagonists are contraindicated in patients with asthma. Alright, so the third point that I raised was the production of toxic metabolites, and in some cases, a drug metabolite may possess toxic properties, and um, clinically significant example of that is acetaminophen. So, in its therapeutic dose range, acetaminophen is predominantly um, metabolized by glucuronidation and also sulfation. That's the phase 2 reactions or phase 2 of biotransformation, and that's about 95%. But then, um, SIP 450, cytochrome P450, um, enzymes oxidize a small percentage of acetaminophen to a reactive intermediate, and that one you're dealing with phase 1. So the reactive intermediate not key, that's what they call it, but it's N-acetyl benzoquinonamine. Yeah, so N-acetyl benzoquinonamine, it undergoes glutathione conjugation, and then when the levels of acetaminophen exceeds the therapeutic range, the glutathione stores in the liver become depleted. Alright, so one thing I have to realize is that this results in excessive accumulation of N-acetyl and benzoquinonamine, and it's an electrophile which reacts with cellular proteins. So although the biological mechanisms is still not well understood, some of these complexes between drug metabolite and cellular proteins are highly toxic in the liver. Yeah, okay, so the fourth point I raised was the harmful immune responses. So xenobiotics or drugs in general can be recognized by the immune system as foreign bodies. So small drug molecules with mass of less than 600 Daltons are not direct immunogens. Yeah, they're just haptens. They act as haptens. But when these haptens bind, often covalently, to a protein in the body, they are capable of triggering an immune response. And if the drug is sufficiently large, for example, a therapeutic peptide or let's say a protein, it may directly activate the immune system. And the two principal immune mechanisms by which drugs can produce adverse effects are hypersensitivity responses, that is allergic responses, and also autoimmune reactions. Alright, so with hypersensitivity responses, they are classically divided into four types: type 1, type 2, type 3, type 4. Type 1 hypersensitivity reactions or response, that's the immediate hypersensitivity reactions. It results from the production of IgE, immunoglobulin E, after exposure to an antigen. So penicillin fragments. Penicillin is quite interesting because it also causes type 2 type. I think we'll come to that later. So penicillin fragments can act as haptens and are responsible for such hypersensitivity reactions. Right. So type 1 hypersensitivity response often results in skin lesion or a flare reaction, and in the respiratory tract can cause rhinitis, and that's the upper respiratory tract. But with the lower respiratory tract, asthmatic bronchoconstriction may even occur. So in type 2 hypersensitivity reactions, which is the antibody dependent cytotoxic hypersensitivity response or reaction, it results when a drug binds to the cells and is recognized by an antibody, usually IgG or IgM. IgG in chronic infections, IgM just an immediate response. Type 2, they are rare hypersensitivity response to these therapeutic drugs of toxicological importance, but it can occur with a drug like quinidine for malaria, and I mentioned penicillin also. Alright, so type 3 hypersensitivity responses, the immune complex, another name is immune complex mediated hypersensitivity. It occurs when the antibodies, usually IgG or IgM, are formed against the soluble antigens and forms the antigen antibody complexes, and these complexes are then deposited into kidneys, joints, and lung vascular endothelium, causing all these lupus-like symptoms. Yeah. Alright, so these complexes can damage. They cause damage by initiating the inflammatory response called serum sickness. Examples of drugs that may pose a risk of serum sickness are propion and cefaclor. Alright, so type 4 hypersensitivity response, that's a delayed hypersensitivity, results from the activation of T helper 1 cells and also cytotoxic T cells, and it's most commonly present as contact dermatitis. So type 4 delayed hypersensitivity, and when a substance acts as a hapten and binds to host proteins. So hypersensitivity reactions of this nature have been observed with the use of ciprofloxacin. Right, so autoimmunity results when the organism's immune system attacks its own cells, and a number of drugs have the propensity to initiate autoimmune reactions. For example, metaldopa. Metaldopa can cause hemolytic anemia by eliciting an autoimmune reaction against resource antigens. Metaldopa we use it usually in pregnant women managing preeclampsia and even postpartum eclampsia and the rest. Alright, but this effect too could occur. Several other drugs like hydralazine, isoniazid, prokinamide, they can all cause these lupus-like syndromes too. Okay, so another reaction that I spoke about is the idiosyncratic toxicity. And with this, you can give a medication to so many people, like acetaminophen, apart from its hepatotoxic effect, and give it to so many people. When you have this weird reaction or adverse reaction occurring, or a symptom that is not usually associated with this particular medication, is idiosyncratic. The obvious mechanism is it's not apparent. It's rare adverse effect that occurs. You don't give this medication to something simple as vitamin C that everyone takes, but then a patient responds to it or reacts to it in a very peculiar way. Yeah, that's idiosyncratic reactions, and it's difficult to really explain this, but then it's presumed that individual genetic differences have a role to play in idiosyncratic toxicities, and they reflect these unique individual genetic differences. So pharmacogenetics, which is this field, may actually help to elucidate mechanisms that underlie idiosyncratic drug reactions. So this is a summary of or something brief about some therapeutic drugs of toxicological importance.